pentobarbital, for example, have been shown by Dr. Ackerman that although did not increase the activity in the lateral muscles, did not impair the activity in the diaphragm. Also, oxygen or CO2 inhalation have been proposed for patients who have increased chemoresponsiveness, which means they very robustly they hyperventilate to a hypoxic or hypercapnic stimulus. Why we're saying this? Because you can see here for this interesting flow chart that the same basically anatomic defect of the airway, an anatomical defect of the airway, which means the flow of the airway is less than 30% of the flow that this particular patient needs, can be associated with various polysomnography features, polysomnography phenotypes, starting from simple stable snoring till hypercapnic obstructive sleep apnea. And why is that? Based on what is his arousal threshold and what is in relationship to effective recruitment threshold for the dilator muscles. So I wonder how these different types of patients, okay, may be responding to opioids. They may have totally different responses. So that's a very interesting study. I don't want to, it's basically Bernard and his group, they gave remifentanil infusion to 19 volunteers that they randomized actually 19 volunteers, 10 volunteers to receive remifentanil and 10 placebo, although all 19 volunteers had a baseline polysomnography study. And then what they found was that remifentanil infusion, pretty good dose. This is even good dose for intraoperative analgesia. They found that remifentanil decreased obstructive apneas and increased central apneas. But interestingly, this significant increase in central apneas was attributed to only 4 patients who presenting with this pattern. They increased very robustly the switch to central apneas. Of course, we had a decrease in REM sleep, an increase in arousals, okay, in this group. But this also shows the variability, okay, among patients in terms of their response to opioids. These were healthy volunteers. There's no surgical stimulus or pain involved. So seeing this data, it's probably a good thing to start thinking, I mean, what are the possible risk markers for opioid-induced ventilatory impairment in obstructive sleep apnea patients? So a high arousal threshold, a low chemosensory sensitivity, morbid obesity, daytime somnolence hypercapnia. Is this the obesity hypoventilation syndrome? We treat obstructive sleep apnea patients every day. We don't experience significant problems, especially if I hear those percentages, like 17% of our patients have moderate to severe sleep apnea. So maybe there are some specific groups of sleep apnea patients who are at higher risk. We don't know who they are yet. What about comorbidities? Diabetes has been shown that it has diabetic patients an altered ventilatory control due to central and also peripheral neuropathy associated impairment of the ventilation of the respiration. Overlap syndrome, OSA and COPD together. Congestive heart failure, there is excessive circulatory delay in congestive heart failure patients, which makes the system even more unstable, from obstruction to obstruction. Renal failure, probably for pharmacokinetic reasons, but I'm not totally sure about that. Maybe some increased sensitivity, pharmacodynamics is also involved, because we see in end-stage renal failure, for example, it's a comorbidity in which there is very high prevalence of obstructive sleep apnea. And we see it all the time in those case reports or retrospective review analysis for opioid-related critical events. So how we mitigate, this is my last slide, how we mitigate that risk. So we're trying to move this respiratory depression curve to the right. Of course, minimize opioids. How we do that? Regional anesthesia. Selective reversal of ventilatory depression, respiratory depression by ampakines, by possibly the GAL 021 that was presented here today. These are agents that selectively reverse ventilatory depression. They do not touch analgesia. Use of O2 judiciously. Maybe those particular patients who have a low chemosensitivity, they don't require so much the oxygen. Maybe oxygen is bad for them. How we deal with ergonomic collapsibility? Use of CPAP. Problems with compliance. Yes, recent study, randomized trial by Dr. Chang showed that problem. Although they are effective in reducing apnea events postoperatively. Ketamine, use of ketamine has good analgesic properties and preserves the activity of the dilator muscles. Genioglossus stimulation by some type of agonist coming up. I'm not sure I know any of those agents. So sedation, decrease the sedative state of your patient as soon as possible after surgery. Use insoluble volatiles, use anesthesia. Use multimodal analgesia to decrease the requirement for opioids. Acetylcholinesterase inhibitors, physostigmine. Although physostigmine has been shown to cause some weakness in the diaphragm and the dilator muscles, it has been used, first of all, in the anesthesia, in anesthesia research literature. Physostigmine was able to reverse propofol-induced sedation in volunteers. But also in sleep medicine, it was tried some time ago in obstructive sleep apnea patients, and it has been shown to significantly reduce REM-related apnea. So if it works in the postoperative period, that will be even better. Yeah. So how we move analgesia towards this side? Multiple analgesia, add ketamine, and whatever else can, take some opioids out of the way. Thank you very much. Okay. Thank you. That was your say. Okay. Sorry if I...
No, it's okay. Thank you. So our last talk, and thank you for your patience. It's going to be given by Dr. Kimo Murto. He's assistant professor and director of research at the Children's Hospital of Eastern Ontario, which is affiliated with the University of Ottawa. He's director of cardiac anesthesia, medical director of daycare and recovery room, a lot of stuff. Medical director of the hospital, research interests. His research interests include acute pain management, clinical prediction, decision-making tools. And he's going to talk to us on analgesic management in children for tonsillectomy and editing. Thank you.
Thanks so much for inviting me to speak, and thank you for those that have survived and are still here. I really appreciate you staying around to listen to what I have to say. I'm just going to carry on here just for time's sake. You've already seen this slide, so there's nothing really more to add. So the objectives today are to really understand some relevant considerations for post-TNA management in children. I want to bring up some controversies with regards to the role of opioids, NSAIDs, and steroids. And then finally, hopefully you'll be able to leave, those of you that are still left here, to leave with some guiding principles for post-TNA pain management in children. So as I mentioned before, TNA surgery is quite common. It's about 500,000 per year. This is data from the Olmsted County, Minnesota, which is felt to really reflect the trends in North America over the last 35 years. The yellow bars essentially represent the percentage of cases performed to manage OSA, The brown are those that have to do with infectious or infectious causes, and then the blue is the infectious causes, and the brown is sort of the combination of obstruction and infectious causes. And so you can see that right now, 75% of TNAs that are done in children are due to a suspected or presumed OSA. And when I say presumed, what that means is that less than 10% of children that are coming for surgery actually have had a definitive sleep study. So for those of us that are assessing these patients preoperatively, whether it's a surgeon or an anesthesiologist, there's a lot of patients that we're really not clear as to whether they have OSA or not. I did mention in the notes that there is a recent randomized controlled trial that looked at watchful waiting versus TNA to see how patients fared afterwards, and the data seems to suggest, even though the primary outcome wasn't positive, that there is improved apnea, hypopnea indexes, quality of life, et cetera. So we're going to continue to be doing these surgeries. The only other thing you should be aware about is that a lot of these surgeries are now being done in sort of standalone surgery centers as opposed to affiliated with some hospital. So that is a current concern with regards to postoperative management of these patients. You can't admit them overnight. So if we're going to continue doing surgery, then what is the problem? Well, prolonged pain is the problem. Here's a 7-day pain data of 51 children post-TNA treated with codeine and acetaminophen. The pain tool that was used is something called the Parent Postoperative Pain Score. The threshold there of 6 out of 15 is essentially equivalent to 4 out of 10 on a VAS score. And the bars that you see are representative of the 90th and the 10th percentile of patients. And it's really apparent by day 7 that there's still a lot of children that have pain. I'm sorry. Yeah, I won't. And by day 10, it's only then that most children no longer have any significant pain. Now, the other thing that you need to be aware of is that there was a recent study that was also published essentially looking at the patterns of parents administering analgesics to their children post-TNA. And what was very, very interesting is that on postoperative day 0, or day 1 actually, about 85% of parents identified that their child had severe pain or moderate to severe pain, but 25% of these children either had none or 1 dose of analgesic. And actually, when you look on postoperative day 4, it actually gets worse. 70% of parents are saying, my child has a lot of pain, but 41% of these children either received none or 1 dose of analgesia. All right, so there seems to be a cadence as that you move away from the day of surgery, you're receiving less medication, and there may be all sorts of reasons that they didn't delve into, but there are some concerns from parents about addiction. We don't solve problems like this in our household with medications, et cetera. So I think the only other thing that you need to consider when you're thinking about analgesia is that from a kid's point of view, the stuff has got to go down pretty easily, so it should be in a suspension, and it's got to taste good. So that's important when you're choosing your analgesic. So what's so bad about pain? Well, first, there's really the moral and ethical obligation that I spoke of before to treat pain. There's 2 types of pain. Probably the more important of them is the dynamic pain, where you have problems with swallowing. And what it does is it results in all of these other negative outcomes. And we can't forget that there really is an economic burden that's imposed on the family, where they're calling you up to deal with whether it's pain, nausea, and vomiting, or dehydration, which are really the top 3 reasons why the surgeons particularly get the phone calls. So I don't have to, everybody here is quite knowledgeable about Karen Brown's work in Montreal, essentially showing what was just discussed in the last talk. I just sort of draw your attention to the lower publication where they showed that they created a protocol where they decreased intraoperative opioids by 25%, decreased it by 50% postoperatively, gave them a dose of Decadron of about 0.24 milligrams per kilo, and they were able to reduce postoperative airway interventions in kids with severe obstructive sleep apnea by 50%. Now, you have to go to the mountains of Lima, Peru to look at children that are walking around with saturations of about 92% because they're at altitude. And when you look at those children's fentanyl requirements post-surgery, they're reduced by 40% compared to their counterparts at sea level. So the model seems to hold out even in healthy kids. OSA and perioperative risk. Well, there seems to be overwhelming evidence that children with OSA have a higher incidence of respiratory complications. There seems to be pretty strong evidence that the severity of OSA confers risk. Now, estimated post-TNA mortality right now is about 0.6 per 10,000, but the databases capturing this aren't very good because remembering that there's a lot of standalone ambulatory centers that are doing these cases, and they're not necessarily inputting their data. Now, this is some insurance literature that came from the northeastern United States, and these are cases that went to trial versus those that were settled outside of court. So really, these cases represent only the tip of the iceberg. And what becomes apparent is that children have respiratory events that account for the majority of their postoperative problems compared to adults. And in fact, children had a twofold increase in postoperative respiratory events compared to adults. Bleeding only accounts for a third of the morbidity and mortality in children, where it tends to be more prevalent in the adult population. So this paper reviews essentially why the FDA recently instituted a box warning, soon to be a contraindication to codeine for managing post-TNA pain in children. You may not be aware, but in Health Canada, there's also a recent restriction for codeine to only be administered to children 12 years of age and up. And this paper, what it was interesting about it is that it shows of the known, and I say of known deaths and near misses related to codeine that are reported, only half of them are actually reported in the medical literature. And of those that are reported in the medical literature, only half of those are actually related to what we call ultra-metabolizers of codeine. So they get essentially a morphine overdose. So there's the other half that are normal metabolizers of codeine, and so you suspect that there's probably some sort of association with opioid sensitivity in patients with OSA. And if we want to review sort of codeine metabolism, it's essentially broken down into an inactive metabolite. This is probably an active metabolite, but where the money is actually with the CYP2D6 that converts it into morphine. So if you remember, codeine is a prodrug, it's not active. Morphine is an active metabolite of this drug. Now, morphine itself gets broken down by the UGT system into morphine 3, which is, again, not an active metabolite. But the morphine 6 glucuronide is a metabolite that has about a 1/3 to a half potency of the morphine. So here you have an example of going from active, more potent metabolite, and from morphine you're going to a less active, potent metabolite. And you just keep that in mind. If you look at the children that have problems with poor metabolism of codeine, so that they don't get the experience of morphine, do this. Essentially what we're looking at is about 5 to 10% of the Caucasian population are poor metabolizers, but where you see the frequency of the ultra-metabolizers that are getting the boluses of morphine, you're tending to see them in the Spanish, African, as well as the Saudi Arabian populations. So this is a table right now that I put together looking at the options for post-TNA pain from an opioid point of view. Morphine at the middle of the chart is essentially your prototypical opiate, which all the other opioids are more or less derived from, so it's got a strength of 1. This is your dosing. It's mainly mu receptor, but again, its metabolism is not based on CYP2D6, and the metabolite itself, again, is a less potent metabolite. In contrast, when you look above here, you have drugs that are either a prodrug, which is codeine, or oxycodone and hydrocodone that have some mu activity, but they require being broken down into their more active metabolites via the CYP2D6 system. So more active metabolites basically are a consequence of these agents. Now down below, I'll mention tramadol. Tramadol seems to be the heir apparent when you read the literature that if we can't get our hands on codeine, let's go with tramadol. Tramadol it's a less potent agent, and when you look at its mechanism of action, primarily in its parent form, it's mainly a norepinephrine and serotonin uptake reuptake inhibitor. But when it gets broken down, it too gets broken down into a more potent metabolite, the M1 metabolite, which primarily gives you your mu receptor effect. Now I'm going to draw your attention to Pendolol. So this is a drug that's being used in the adult world. It's been touted to be sort of efficacious, similar efficacy to oxycodone, has less gastrointestinal problems with it, seems to be well tolerated, maybe less sedation, less respiratory depression. It is a norepinephrine reuptake inhibitor, and what's very interesting is that, again, like morphine, it's not metabolized. In fact, it's not metabolized whatsoever, all right? So there's no active metabolites of tapentolol. So when you look at the predictability of the pharmacokinetics of the active moiety of all of these agents, tapentolol is probably number one, followed by morphine, and then you have all of the unpredictability of the CYP2D6 that's involved with the metabolism of these other drugs. And so this is a typical picture taking place in your dorsal horn. You've got the C fiber that's presenting your noxious signal. You have substance P and glutamate that crosses the gap, your secondary afferent, then conducts that noxious symbol up the ascending pathways to the brain. You experience pain. But you have these descending pathways from the brain that are also involved in modulating the conduction of this noxious stimulus. So you have norepinephrine that's interacting with the alpha-2 adrenal receptor, serotonin receptor. So if you look at what tramadol is doing, so the racemic form of it, the parent compound, is primarily dealing with inhibiting reuptake of norepinephrine and serotonin, and it's also promoting a little bit of serotonin release. So all this serotonin floating around is bringing up some concerns with regards to a lot of nausea and vomiting with this drug. And it's through the CYP2D6 that you get that more active M1 that's actually interacting with your mu receptors presynaptically. And again, it's a more active metabolite. So if you look at tramadol, if it is an heir apparent, it's got some advantages and disadvantages. There's something warm and cozy about the fact that it's been around for many, many years, kind of like clonidine. There's potentially less drowsiness and respiratory depression, less GI effects, less chance for dependence or abuse, because if you take a lot of it, you tend to get seizures. So it's not a great high if you're going to abuse this drug at home. Again, disadvantages, it's basically dependent on the CYP2D6, so you have the genetic issues of there, the nausea and vomit we've already talked about, and also there's some papers that are saying that ondansetron may actually counteract the analgesic effect of the drug. And if same situation here, so essentially when we look at tapentolol, this is what tapentolol is doing. It's blocking the norepinephrine uptake. It's got some mu effect, and there may be a little bit of serotonin reuptake inhibition, and that's it's sort of questionable as how significant it is, but right now they're saying that the drug should not be taken if you're taking SSRIs, MMIs, et cetera. So, another controversy is the NSAIDs post-TNA bleeding. So this is basically ground zero. In 2003, there was essentially 3 studies that came out, meta-analysis, systematic review, 2 out of anesthesia journals, 1 out of a surgery journal. These are the number of patients. They're basically combined children and adults. And essentially you go from, the first study says that, you know what, bleeding risk is increased, but you know, from a reoperative point of view, one study says, it's probably not an issue, but we didn't really look at it, and so go ahead and use ibuprofen and diclofenac, but avoid aspirin. Another one said, well, you know what, you should probably use NSAIDs cautiously, and the third one said, you know what, you shouldn't use NSAIDs. So Cochrane comes around in 2005 and subsequently has updated its review up until June or July of 2013. Essentially, they've got a whole bunch of patients now, primarily children, and they see no differences. And so they say no risk, but further studies are required. And what they're getting at is that if you're looking at an outcome like bleeding that happens about 2 to 4% of the time, any intervention that's going to affect that outcome that's quite rare, you need a large sample size to be able to prove definitively whether there's an impact or not. That sample size is probably about 2,200 to 2,400 patients. So I want you to remember that number, 2,200 to 2,400 patients. So lo and behold, there's just a recent publication that came out, a meta-analysis, child and adults, but they've achieved that sample size. And essentially they showed that there was no increased bleeding risk or a reoperative risk. NSAIDs are safe. And in fact, if you compare children to the general population, the risk of bleeding is actually less in children. And so if you look at their data here, this is sort of just the kids on their own, 1,600 versus the 1,100 in the Cochrane review. The odds ratios were similar. They looked at diclofenac and ibuprofen, and essentially they showed, even though their numbers are smaller, you're not getting that 2,200, we're at about 400 and 500 patients, they showed that the odds ratio was, didn't seem to suggest that there was a problem, which really coincides with this first meta-analysis, but it also coincides with this retrospective review that was done in the United States a few years back, where there's essentially two centers, one that used ibuprofen on a regular basis post-operatively, and another center did not. And so they're split about 60-40, and between the two centers, they showed that there was no difference in bleeding whether you used ibuprofen post-operatively or not. And finally, I'd just draw your attention to ketorolac, even though the numbers are small, if you look at the confidence interval of the odds ratio, it's up to 17, and you have that p-value is at 0.13. There's something there, there's a signal. And so you'll see in the literature that you probably shouldn't be using ketorolac. And the reason that is that it's probably the most potent of the COX-1 inhibitors of all the NSAIDs, while diclofenac is probably a poor man's COX-2 inhibitor, which COX-1 to 2 is probably about 1 to 10. And if you look at ibuprofen, it's probably 50-50. So you've already seen this, so if we're talking about COX-2s, the only thing that I didn't show you with the previous slides, I showed you data up until about post-operative day 2, and what we showed you is that there was reduced analgesic, acetaminophen and morphine. But what's very interesting is that on post-operative day 3, there's a spike. Those that had the celecoxib and then stopped taking it all of a sudden get a little more pain than the placebo group because they weren't loading themselves with the acetaminophen and the morphine. So the celecoxib was actually doing the yeoman's work of taking away the pain. So this is something to realize that, it shows us, again, more emphatically that celecoxib is effective, but also shows that the clearance out of children is probably, at least twice as fast as that in the adults, and the half-life is probably about half as long as what it is in adults. So you don't get that lingering effect like you do in adults with regards to celecoxib, and you probably, with our ENT colleagues at CHEO, we're administering celecoxib out to day 7 to day 10. Now, we're going to be evaluating this scientifically to make sure that there aren't any problems, but that seems to be the way to go. And you already saw that. So here's dexamethasone and post-TNA bleeding. So this is just another one of these controversies. Ground zero is this JAMA article in 2008, and essentially what they were doing was a study. It was a randomized controlled trial where they're looking at placebo versus IV dexamethasone in a low dose, 0.05, 0.15, and 0.5 milligrams per kilo administered intraoperatively. And their primary outcome was nausea and vomiting. And so they had 215 children. When they did an interim analysis, they said, oh my, we're getting a whole bunch of patients that seem to have a lot of bleeding, and therefore they stopped the trial. But when you look at it, the bleeding was with the low and the high dose, but the middle dose was very comparable to the placebo. So there didn't seem to be any biological response there. And so essentially their recommendation was, you should be concerned about giving intraoperative steroids to kids. So this created a tremendous uproar in the literature, and there was all sorts of criticisms. And the primary one was that their primary outcome was nausea and vomiting, and how could they comment on bleeding? When they looked at rejigged the statistics, the lower dose didn't seem to have the bleeding. The higher dose still had the bleeding, but when they took out the primary bleeders, so those that happened within 24 hours of surgery, when they took those out, all of a sudden that significance went away. So next thing you see is there's a systematic review of about 1,500 children and adults. Bleeding risk, no difference. Again, a surgery journal doesn't talk about reoperation, which I don't understand why. And they said that perioperative administration was safe, but again, they had a signal to say that, kids seem to have a little bit more bleeding, but it doesn't seem to be significant. So I looked at the data, and essentially when you look at the kids, a typical kid undergoing surgery who's about 5, weighs 20 to 25 kilograms, the median dose that they were getting was about 0.5 milligrams per kilo, and the median maximum dose that they were getting was about 11 milligrams. So JAMA, they do an RCT. It's a non-inferiority trial looking at placebo versus IV dex, again at the 0.5 milligrams per kilo, which is contentious. Because it's a non-inferiority, they can get around that 2,200 to 2,400 patients with a sample size of 314. And essentially, they show that there's level 1 bleeding, so non-clinically relevant bleeding, so the parents say, my child spit up some blood. But they didn't get to level 2 bleeding, where these patients actually showed up to hospital, or level 3 bleeding, where they actually had to undergo surgery. So they say a single intraoperative dose of 0.5 milligrams per kilo is safe, but it may cause some mild bleeding. So you're starting to see a pattern here. So laryngoscope, they do a meta-analysis primarily of children. Essentially, again, no increased bleeding. Again, don't comment on reoperation. And they do mention that in their subgroup analysis, 0.4 to 0.6 milligrams per kilo range in children, there seems to be a signal for bleeding. So here we are, we're waiting for that paper that has a 22 to 2,400 patients. The BMJ just recently published a systematic review and meta-analysis, and this is the number that they achieved. And they showed that, you know what, there isn't any increased bleeding when you're using intraoperative steroids, but boy, you know, if you do get a bleed, there's an increased risk for reoperation, so that the bleeds seem to be more serious. And so you should be using NSAIDs with, or dexamethasone with caution. And when I again looked at the dosing, the kid's median dose was about 0.5 milligrams per kilo, and the maximum dose in this, all these trials was probably around, the median maximum dose was about 15 milligrams per kilo. So there's this pattern. So you see something about this 0.5 milligrams per kilo single intraoperative dose seems to be a threshold. So the last two slides are looking at the guiding principles. So in general, so indication for TNA will guide pain management. So a very simple question you can ask when this patient's coming to your OR or your preoperative assessment clinic is that, is it for OSA? Then I'm concerned. If it's for recurrent pharyngitis, maybe I'm not as concerned, but again, we know that we're not very good at diagnosing, but at least it gives you a starting point. Oral medication, think of oral medications as an intravenous agent. So what we're doing is we're preloading our patients with acetaminophen 30 milligrams per kilo orally before they go to the OR, because you want to rapidly attain an analgesic level that will help with their emergence and perhaps get them out of PACU daycare and out of the hospital a little faster, as opposed to giving them either a rectal dose where the systemic absorption is very unpredictable. And finally, engaging parents and child. You're going to see a lot of this now in the protocols that are being published, and here's an example of two that I think are quite good and complement each other. And it's just getting the parents better to be able to identify pain as well as how to manage it, and also get the kids involved as well. There were some concerns that you may promote some pro-pain behavior in kids, but actually getting them involved doesn't necessarily turn out that way, and that it's probably a useful thing. From an opioids point of view, you're dealing with an unpredictable environment when it comes to children showing up to the OR in regards to their OSA or severity of it and what they have. So it's an unpredictable environment. So what we suggest is that we want to put some predictability in the environment for you when you're managing them. So you may want to strive for optimal pharmacokinetics of that are predictable of the most active moiety of whatever opioid you think you should use. We are using morphine. I did asked my colleagues across the country in Canada, and most are going to morphine now that we can't use codeine. Avoid around-the-clock dosing. You should really be using opioids as breakthrough pain, and you should just have that double barrel of the acetaminophen and an NSAID taking care of the problems. And again, decrease your dose by 50% for those children that have severe OSA, but to be safe, you probably want to pull back to moderate OSA if you know the diagnosis. From an NSAID's point of view, we know that they're very effective in decreasing nausea and vomiting. They're very good for dynamic pain, so that's the pain that you have with swallowing that we want to deal with. Considering these drugs, they seem to be reasonable approaches. This is ibuprofen is more of a North American concept versus diclofenac is more European. But we don't know, when you combine it with acetaminophen, what is the dosing schedule, how you should spread it out over the course of the day. But what I would suggest is that you probably try and bother the child the least amount of times as possible to make sure that they're going to be compliant and take the medication. Avoid the ketorolac, and celecoxib is evolving. We're looking at a new study now where we're going to be bolusing them with higher doses preoperatively and higher maintenance doses, but still sticking with the BID dosing, because again, I don't want to rile up that child too much during the day. Dexamethasone, if you think there's a dose response, then the 0.2 to 0.25 milligrams per kilo with a maximum of 8 to 10 milligrams seems to be a reasonable place to go. I can't tell you with scientific accuracy if it's true or not, but it seems to be from the notes that I provided with you that you're getting the analgesia, you're getting the nausea and anti-emetic effect, you're getting them to take PO intake a lot faster than they normally would, but you're likely avoiding the problems with bleeding or the concerns that there are. Acetaminophen, we've already really talked about. Ketamine, Depends on your anesthetic technique. Intraoperatively, if you are not using long-acting opioids like morphine, but you're using fentanyl, or perhaps you're really concerned about the patient, you're not using any opioids, ketamine seems to perform pretty well. But once you put a long-acting agent like morphine in there and then you throw the ketamine on top of that, it's probably not going to be helpful, and it may prolong your discharge from PACU and daycare. Topical infiltration is hard to say. I won't talk much about that because the studies aren't great. Alpha-2 agonists, dexmedetomidine, this great drug. Again, if you look at the literature, if you're using morphine in your practice, dexmedetomidine 1 mic per kilo is about the same as morphine 100 mics per kilo. So you're not really getting any added benefit unless you're really concerned, and there are people that are doing a 50-50 split of 0.5 mics per kilo of dexmedetomidine and 50 mics per kilo of morphine to sort of counteract that concern. Or you can actually use dex and ketamine together. It's the yin and the yang, and they actually complement each other quite well. The role of clonidine, we don't know what that is. It may prolong discharge, not necessarily because they're sedated, but it's that facilitated arousal that your PACU nurses aren't familiar with, where they see a sleeping child and they think it's a midazolam hangover, but really, no, it's clonidine. It's facilitated arousal. You know what? They're not probably going to get apneic on you. You're okay to send them on their way. And then finally, local infiltration with local anesthetics. We don't do it at CHEO because there have been concerns, some of which have been, I believe, reported at CHEO itself, where they've injected into a carotid artery or injected into a vertebral body. You do get some sort of transient analgesic from it, but otherwise, it's on the short term, it gives you a little bit of benefit, but long term, it's questionable as how useful it is. And that is that. Thank you.
Thank you. We don't have time for questions, so we'll have the speakers hang on here after the meeting. So if you have any questions, please come by and talk to them later on. So at this point, I'll hand over to Dr. Baba.
All right, so I don't know if you're waiting here for the iPad. It's already been spoken for by myself. Just kidding. So here's the list. I'll have Francis pick up one. I hope I pronounced it correctly. Julie Civello. All right. Here you go. Well, thank you all. I just want to say that if you have any suggestions or comments about next year's meeting, what topics you're interested in hearing, and please go ahead and share that with us. Our emails are readily available on the internet. Mine, Francis, Dr. Hillman, Peter Gay, Rubka, any one of us, please feel free to share, because what we like to do is put programs that is of interest to our membership. So thank you very much.